actually much higher doses of AZT than we needed to early on. That's part of the toxicity profile, adverse profile that it had early on. But AZT has turned out to be a very valuable drug. It's still a drug we use frequently in the clinic. It's had quite a durable market and still is a benefit to people who can't tolerate some of the newer drugs in that class.
Well, is that, I mean, you know, of course, Dennis, I think from prior conversation with you, you know, even on set, that you also took AZT, I guess, at one time. I can't remember if you still do or not, but how did that help you?
Well, I didn't take it in the early days. I didn't, in fact, I'm what they call a long-term non-progressor, so I didn't start on any antiretrovirals until about 18 and a half years after I was infected. But so I am on a form of AZT, but it's today's version of AZT called Sustiva. It's part of it. So I didn't have to deal with the toxicity of the higher doses that people were facing earlier on.
And Nevin, what about you? You know, of course, I don't know your background as far as your health background or any of that. I met you.
Okay, I was diagnosed with HIV in 1991, and I immediately had blood work done to check my T cells. My T cells were 183. So I was put on AZT five pills 3 times a day. And I helped build the chart. I was on every medication that's out. I have resistance and mutation. That's why I get into AIDS clinical trial units, because that's the only place for me to go, because nothing works.
Right. Well, I mean, you know, Dr. Schouten, even for you, I would imagine, you know, looking back in the 80s and finding, you know, the very little back then that was known about it. I mean, back in, I think, who was president back then? Ronald Reagan?
Yeah.
It was not, you know, nobody knew. Everybody was sitting back scratching their head over it. But would you say, though, that since the 80s that knowledge has definitely increased, clinical trials have begun, and that it's helped millions of potential patients?
Sure. I mean, most of the things we do every day in the clinic now we didn't have available then. Things like Nevin was talking about, drug resistance testing. We didn't have that technology available. Measuring viral loads. We didn't even know how to measure HIV. HIV wasn't even discovered until 1984. The first blood test to test for HIV was in 1985. But since then, we've made tremendous advances that have spilled over into other areas of medicine. And there's been kind of incremental gains, and we've had a couple of major breakthroughs, the protease inhibitors being a major advance, triple combination therapy as a result of the data presented in Vancouver in 1996. And then I thought, and I think a lot of people thought a few years ago, because there were a fair number of drugs, we were up to almost 20 FDA-approved drugs, that drug companies would stop investing in the pipeline and research. But what we're actually seeing is a fairly healthy research and development going on. And just in the last 2 months, we have 2 new drugs approved, 2 different classes, mechanisms of actions. It continues to be a very dynamic field and an exciting field to work in as a professional. And also for people like Nevin was talking about, for the research unit, we continue to have new compounds available to help people who have, because of the sequential drug development that we had in the 80s and 1990s, develop resistance. We no longer treat people initially that way, but that was the best we had to offer at the time. So we have a very rich pipeline of products and compounds still in development. So it still attracts a lot of investment and research.
Well, even, you know, as a researcher and a medical doctor, you know, again, looking back in the 80s, what would you tell patients even back then? How would you deal with it? You know, with very little known about it, you know, very little understanding maybe as far as drug compounds or the availability of drugs back then. What was the expected lifespan back then of somebody that had HIV or AIDS?
A year.
I think it depends at what time, at what point you presented with your illness. But certainly if you presented with a serious life-threatening infection, you only had a year or 2 to live. You know, I think that, and the media was saturated with the message that universally fatal. How many times did we see newspaper headlines, a universally fatal disease? And we still deal with that misconception in patients newly diagnosed today, even though there's tremendous apathy about HIV in the communities at risk. there's still people who perceive it to be an infection that's going to kill them. So when we start talking to people about not smoking or eating better, they kind of roll their eyes because they think it's still universally fatal, which is not. The new treatments actually, people are probably going to live out their life and die of other causes, not of HIV/AIDS related causes.
Right. Well, Dennis, back to you for a minute. I know back many years ago, back in the 80s, we had talked about it and what was going on in your life back then. But I don't know that something maybe stood in the way of you being able to get preventative help back then, or exactly what happened. But what made you take as far as the medication from back then that was offered, as little as that it was? What made you, or what has kept you going from then to now, knowing that maybe one drug was all that was out there in the market to be able to help you?
Well, for me, I focused more on trying to feed my immune system as much as I possibly could before I had to go on the meds.
What do you mean by that?
Well, diet, exercise, positive thinking, mainly diet and exercise, but in the form of diet, some supplements that I would get at the health food store, garlic supplements for one thing, because they have a lot of properties that help feed your immune system. But when the only treatment was the high doses of AZT, I saw friends of mine that were asymptomatic, and then because they were afraid to not do anything, went ahead and started on the high doses of AZT, and I think they inadvertently harmed themselves at that point, because people just didn't know. The medical community didn't know. They were trying to fight something that they weren't able to really fight effectively at the time. And that's all they had, were these high doses of AZT. So I took the stand that until there was a better treatment developed, that my best option would be to feed my immune system and try to outlast the disease before it progressed in me. Hopefully, I mean, that was my hope. I didn't know if it would work or not, but that was my hope. And for me, it worked. But like I said before, I'm what they call a long-term non-progressor, because I had the symptoms of seroconversion, or converting to HIV positive, a few months after my partner Shane and I had gotten together, and we met in December of '82. And the only time I had the symptoms of like a mild flu was in March of '83. And we got tested as soon as the test became available in '85, and we were both already positive then. So I believe at least one of us was positive when we met, because we had a monogamous relationship. And so I just took the stand that since there was no cure and the treatment was so toxic for most people, that my best chance would be to try to strengthen my body, my immune system as much as possible, and hope to outlast the virus in me long enough to the point where I would last to the point where effective treatment would be developed, and that's how it's worked for me. And I've been on the meds now since August of '01 is when I started on the meds. And with one short treatment interruption, just a sort of an experiment really to see if I could do without them. And I found I couldn't because the virus came roaring back. But with that one exception, my viral load's been non-detectable for years now, and my immune system readings are in the very good range. So, but I'm not the normal case. I'm not what you normally see. Most people are not long-term non-progressors. So I've just, through the luck of genetics and maybe some other things, I'm not real sure what all is entailed, but I like to think that I have something to do with it, but maybe I'm just fooling myself. But my efforts are mainly with diet and exercise.
Now here is.
I think this is also one area of research that we're very interested in, is what Dennis alluded to, the tremendous variability in the progression of disease from person to person. And we still do a lot of research and still have not elucidated why some people seem to